Okay, good evening, everyone, and welcome to Plan Your Baby webinar. And my name is Maria. I'm a fertility nurse at Plan Your Baby and a founder as well. And today we will discuss something very important and something that unfortunately we do see very common in our clinic is the IVF after the pregnancy loss and how we can help patients after a heartbreaking miscarriage and also the biochemical pregnancy. So we will talk about the potential treatments. We will talk about the support that is needed. And yes, and I will encourage everyone, please use the chat. Let us know where are you dialing from, what's your name, how old, how young you are, and what kind of treatment you are looking for. We will be going through all of the questions after the presentation in our Q&A session. So if you would like to share with us, please don't be shy. This space is safe, and we are here to support you and help. And hopefully, we will be giving you all of the answers that you are seeking. This webinar got really popular, and we have a lot of sign-ups. So I'm just gonna maybe wait a couple of more seconds. I can see that we have more and more people joining. And yes, I can see that my colleague has messaged as well in the chat. So please feel free to use the chat and ask your questions and let us know your situation, where you're dialing from. Dr. Sami, would you like to go to the next slide? Yes, so today I'm very happy to have Dr. Sami with me, our medical director, and Dr. Nora Sakli, who recently joined Plan Your Baby. And she has more than 20 years of experience helping patients with infertility and recurrent miscarriages as well. So she will be joining our panel and will answer all of the questions as well. And we have a nurse Vivi with me and myself, and as well our clinic's manager who will help me answer your questions in the chat. So Plan Your Baby is a telehealth, fertility and pregnancy clinic. And we have founded the clinic a bit more than 4 years ago, myself and Dr. Sami, after working together for, I think, more than 15 years now coming. And the whole idea was to have clinic that would work for a patient rather than around the clinic scheduler. We have more than 450 partner locations where we conduct the blood test, ultrasound scans, and then Dr. Sami and Dr. Nora has the ability to provide the treatment care from any location pretty much nationwide in the UK. And we do provide a full range of services as well. Dr. Sami, would you like to go to the next slide? Yes. So as I said, so me and Dr. Sami, we've met many years ago, and Dr. Sami has more than 20 years of experience helping patients and extensive experience working in NHS and private sector, and in one of the most busiest clinics in the country. And Dr. Sami specializing in IVF, recurrent miscarriages, as well as reproductive immunology. And I think those kind of topics what we will really dig deep down and discuss today. Dr. Sami, the floor is yours. Please start.
Thank you for that introduction. Yes, so we're welcoming Dr. Nora to our team, and she's going to start our recurrent miscarriage part, and then we'll talk about IVF and PGT-A and things like that in the following slides. Thank you, Nora.
Thank you so much. I'm really excited to join this webinar, and I'm just going to start by talking about recurrent miscarriages. So it's usually defined like 2 or more consecutive pregnancy losses, and it's thankfully not very common. It's 1 to 2% of people, but it can take an emotional toll, and it can be very difficult for couples that are trying again to get pregnant, and they can face a lot of fears during early pregnancy. Next slide, please. So when we look at recurrent miscarriages, there are lots of different causes that can factor in. So it could be genetic, it could be autoimmune, could be a problem in hormones like the thyroid, an issue anatomically in the pelvis or in the womb, which needs an ultrasound, or an immune system. So there are different tests that we can do, and hopefully some interventions to try and minimize these. But when we look at the main causes of miscarriages in general, it's usually a chromosomal issue in the embryo. So that accounts for 50 to 70% of miscarriages. And it's not something that people have done wrong or you have done wrong. It's just random errors that happen during the development of the sperm and the egg, or during the early development of the embryo. Most of the time it's not recurrent, but when it's recurrent, we look into other things. But it can also occur in healthy young women. And the major factor that affects here is advancing maternal age. So when we come to natural pregnancy, we can't really know if an embryo is chromosomally normal or not. The body might not recognize things except later. So we can have early or late pregnancy losses, but when we look, and we were discussing that there were maybe errors in formation of the eggs, as we get older, that becomes more, and that's why miscarriages are older after the age of 35 and more so after the age of 40.
Thank you, Nora, for that. So yes, I mean, the topic of this webinar tonight is actually not just recurrent miscarriage, but talking about the option of IVF after miscarriage. And some people, they wonder, you know, what do I do? I've had lots of miscarriages. Will IVF help me? Will it not help me? What kind of IVF should I be doing? What should I do alongside the IVF? So I see a lot of people with recurrent miscarriage, and actually the majority of them, they don't have a problem with conception. Most of them, they tell me, actually get pregnant very quickly, very easily. Sometimes when they come to me, they've had miscarriages. So many pregnancies, they come to me on contraception, in fact, because they're afraid to get pregnant until they've had the relevant tests and interventions done. But if it does show that the embryo has been abnormal chromosomally, so if someone's miscarried and they've tested the products of pregnancy and it shows that there is a chromosome issue, then we know exactly why the miscarriage happened. Sometimes, however, it's not easy to do that. It's not easy to collect the products, or if the pregnancy fails at a very early stage, there may not be any material to be genetically analyzed. So if we do IVF with recurrent miscarriage, a lot of the time I would recommend to pair the IVF with genetic testing of the embryo, because like Dr. Nora said, the most common cause of miscarriage, 50 to 70%, if you remember, is chromosome abnormality. And if we do IVF and we put the embryo back inside the womb, which is genetically abnormal, then either the woman unfortunately won't get pregnant, or if she gets pregnant, most likely it's going to be a miscarriage. So IVF, at least we can test the embryos with it, and when we put the embryo back, then we can, with 98% accuracy, at least know that the embryo is genetically healthy. Of course, there can still be miscarriage even with genetically healthy embryo. It's about 8% risk, because there are other causes of miscarriage, which is why alongside the IVF, alongside genetic testing, we need to make sure that we've covered for everything that we can. So who may benefit the most from genetic testing? Well, like I mentioned, if there's recurrent miscarriage and we know that there's a genetic problem, then definitely this is something which can minimize that risk. Women who have unexplained, they haven't managed to test the products, again, we can do it. Certainly as a woman gets older, the proportion of embryos that she will make which are going to be genetically abnormal, are going to increase, and it makes it much more worthwhile to do genetic testing then. Or, you know, sometimes we have some patients, they produce a lot of embryos and they are older, however, and each year can have quite a big impact on the quality of the eggs and therefore embryos. At least if she can go through around, check the embryos, we know then that they are genetically healthy when we put them back, rather than putting back many embryos which are not genetically well, and then it just ends up in more miscarriages, more time taken, and of course, not just time, but money, and very importantly, heartache. Facing the miscarriage again and again is a really, really difficult thing. So basic ideas to what's involved is it will be an IVF cycle, and then on day 5 or 6, or even day 7 nowadays, we can do a biopsy, we call it, where we take a few cells, 5 to 8 cells usually, from the outer layer, the trophectoderm, which is the outer layer that forms normally the placenta, not the part that forms the actual baby. So that's done on day 5 to day 7. The embryos have to be frozen because it will take around 2 or 3 weeks to get the results typically. We can't keep the embryos out that long. And the embryo's chromosomes will be analyzed. So we know for each embryo, if it's genetically healthy, which we call euploid, if it's genetically abnormal, we call that aneuploid. It's got the wrong number of chromosomes. Or sometimes we face a situation where it's mosaic, which means that some of the cells have come back healthy, some are not healthy. We can still use mosaic embryos. There's still embryos that can give live birth, but not as high a chance as the euploid, which is the healthy one, and slightly higher risk compared to euploid for miscarriage as well. So it's not our preference. If we have euploid embryos, we always prefer to use them first. And then we will go ahead with a frozen embryo transfer where we prepare the woman to receive the embryo with certain preparations, certain tests. Sometimes we do extra tests like Dr. Nora showed you, we can do tests on the immune system, the uterus, hormones. There are many things that we should check because once we have this euploid embryo, healthy embryo, we want to make sure everything that we can adjust and tweak and optimize is done to give the maximum chance for that woman hopefully to get pregnant and have a successful pregnancy. So these are some figures from a few studies that kind of show miscarriage rates. And with PGT-A, it does reduce significantly the number of miscarriages that can happen. And especially if you cover for more factors, then you can even reduce it even more significantly than what's on this study. Live birth rates are also quite high. So if you have genetically tested healthy embryo, what we see is 50 to 60% of the time across most age groups, really, we're seeing success rates and live birth. And clinical pregnancy, which is, getting pregnant, which is not really the aim here for recurrent miscarriage. You don't want just to get pregnant, but that's also higher as well. But the live birth is the one that we're really interested in here. So yes, you have to do IVF to be able to test the embryos, and IVF is not an easy or straightforward process. We stimulate the ovaries initially to try and get multiple eggs. We then make the embryos in the lab with some sperm, and we test them. And the first part, the stimulation, is the hardest part because the woman needs to have blood test and scan before she begins. She will start then taking hormone injections, and every couple of days, she will do another blood test and scan so that we can see how she's responding to the medication and adjust the medication very carefully. Because if the medication isn't adjusted well, then it can result in fewer eggs, which means fewer embryos and lower chance of having good embryo there. Too much of medication is not good either, because too much, sometimes it can disrupt the hormones in a way that can damage the egg quality or even lead to something called ovarian hyperstimulation syndrome, where the woman can become unwell. So tailoring the stimulation, in my opinion, is extremely important. Then after about 10 to 16 days, once the follicles have reached the right size, we ask the woman to take a trigger injection to mature the eggs. And 36 hours after that, there will be an egg collection procedure. So the initial monitoring is all done local. We have many partner clinics across the country where you can go and have your blood tests and your scans. But when it comes to the actual IVF procedures, which would be, in this case, first of all, the egg collection, then both partners will need to travel down to London to our partner clinic to have the egg collection procedure done there by the doctors there. And then later on, when it's time for embryo transfer again, they will need to travel down for that process. Post-transfer, once we've done the transfer later on, we also monitor the hormones. We monitor mainly progesterone. And if we need to top up progesterone, we can do that to make sure that it's well supported, because sometimes we see a dip, and that can also affect the chance for getting pregnant and how strong the pregnancy may start off. So we do blood tests every 2 or 3 days. And again, that can all be done local to you. Okay. And then pregnancy test will be done, and hopefully, fingers crossed, a positive pregnancy test will be there, at which point then we also want to monitor closely the pregnancy, especially for women with recurrent miscarriage. This is really important. The first couple of weeks of the pregnancy are a really critical time. So in those first 2 weeks, we do blood tests every 2 days, normally every 2 or 3 days, for HCG, which is the pregnancy hormone, and for progesterone, in case we need to top up or increase the progesterone levels with extra medication. And then once we get to around 6 weeks, we arrange for the first ultrasound scan. And if the scan is good, hopefully we see a heartbeat and everything's looking okay, then we can reduce the monitoring to once every 7 to 10 days. Normally we do an ultrasound scan and a progesterone blood test until we get to 12 weeks. Now, hopefully at 12 weeks, if everything is looking good and the screening tests are fine, we can relax at that point, because the risk of miscarriage beyond 12 weeks is much, much less. And that point means that we are kind of quite comfortable that things are looking okay. So, yeah, I've got a few cases here just to kind of illustrate some scenarios which we had 2 patients. So I've got 2 cases that we've seen. And this first case, she's a lady who lived outside of London. 42 years old. She had recurrent miscarriages, so she'd had 3 miscarriages, no live birth, and she'd be trying for 5 years. She initially started off at Clinic 1, and she did really well with her IVF stimulation. She got 23 eggs, 19 of them made to day 5 or 6 embryo, which is blastocyst, which is really, really good number for her age at that point. So initially they tested 6. There were more to test, but they didn't test them all because there's so many. They tested 6 and they found 4 euploid, 4 were healthy. She then went through 4 separate embryo transfers, 1 each time. And unfortunately, even with this euploid healthy embryo, she was unsuccessful. She didn't get pregnant. She then transferred 2 of the untested embryos together, and she got pregnant but miscarried. It was a biochemical pregnancy. She tested the remaining 10 embryos, got 6 healthy embryos, transferred 1 more healthy embryo, euploid, again, negative result. She then decided to move clinic. She moved to another clinic and went ahead with immune testing because she was worried that there could be an immune problem. And it did show high natural killer cell activity. So an elevation of these natural killer cells, which are type white blood cell. And some of these killer cells, when they're very active, they can attack the embryo and make it hard to get pregnant or hard to keep a pregnancy. So this time they gave her some treatments. She did have IVIG, which is a type of immune drip, steroids, prednisolone, and Clexane, which is a blood thinner. Unfortunately, she had a negative result. And then she decided to come to Plan Your Baby. At Plan Your Baby, after I saw her, she'd had 7 failed transfers, actually. We asked her to do a hysteroscopy, which is a telescope to look inside the womb to check the cavity. And there was a polyp, endometrial polyp, a fleshy growth found, which was removed. We also did some further immune testing. So I asked her to check her cytokines, which are protein activators for the immune system. And the most important one is called tumor necrosis factor alpha, TNF alpha. And that was high for her. So pre-treatment, pre-embryo transfer, she took 2 injections of a drug called Humira to counteract that. And then she went ahead and did a frozen embryo transfer with the embryos that she had left, the euploid embryo that she had left from her initial clinic, in fact. And I gave her some Viagra to help thicken the womb because there was a thinner womb lining than what we expected normally. She had just low dose steroids. She had higher dose in the previous clinic. I gave her intralipids, which is a soya drip, again, for the immune system, Clexane, aspirin, and she took extra progesterone in the form of Lubion injections, subcutaneous injections for progesterone. 1 embryo transfer, positive pregnancy test, and we followed her until 12 weeks of pregnancy in our clinic. And thankfully, everything went smoothly and she had a live birth. So another case is a younger woman, very low egg reserve, and she had an AMH of around 2, which is very unusual for her age. Also, her partner had very poor sperm, and they started off in Clinic 1, did IVF. They actually did immune testing with that, and I think one of the reasons to do immune testing is a very low egg reserve at a young age. Sometimes it can be linked with immune problems. And she took IVIG, again, that immune drip, dexamethasone, which is a steroid, Clexane, and she was successful. First cycle, she got a baby in 2021. She came back a couple of years later, tried with the remaining frozen embryo, because she had 2 embryos from that initial cycle. And unfortunately, it didn't survive thawing, which is about 4 or 5% risk. It's not common, but she was unlucky. Tried another stimulation, that same clinic, and 1 embryo was transferred, but unfortunately it was negative. She didn't get pregnant. She decided to move to another clinic, to Clinic 2. This clinic, they insisted that she does genetic testing. I'm not sure I would have agreed with that, but that's what they insisted on. She got 2 eggs, 1 embryo was tested. It was normal, it was healthy, euploid. She then went for another stimulation because she wanted to get another embryo, hopefully healthy. But that cycle, the egg didn't fertilize. She got 1 egg, it didn't fertilize. So they transferred that healthy embryo from the first cycle in there. She did get pregnant, but miscarried. And then she did 1 more stimulation, and she got 1 more embryo, healthy embryo, which was great. But she decided not to transfer it because she had her concerns. She felt that she needed some immune support, and that clinic didn't offer that. So she came to Plan Your Baby. We did a microbiome assessment for her, and she had low lactobacilli, which is the healthy bacteria. So she was started on probiotics to help with that. And then she did immune testing again. She had high natural killer cells. So again, we put her on steroids, dexamethasone, IVIG, the immune drip, Lubion, Clexane, aspirin, and she had a positive pregnancy test. And we followed her to 12 weeks, and yeah, she had another baby and was very happy because actually she told me this was her last attempt. If it didn't work, she wouldn't try any more fertility treatment. So it was a good thing for her that it worked out well. Okay, Maria, I think I'll hand back to you now.
Thank you so much, Dr. Sami. Every time when I see those, happy stories that actually even after such a long journey and so, sometimes can be so heartbreaking, then we still see that yes, there is a hope and the treatment can work and the dream can come true. So yes, that's fascinating to see. And thank you for paying attention and personalizing the treatment plan so much that you actually don't leave any rock, unturned and help patients with such a dedication. In terms of IVF cycle, I think one of the most common questions that every clinic will get asked is the costs, and it is very important topic because unfortunately IVF is very costly, and at Plan Your Baby we provide a transparent, no hidden cost plan, and we provide the personalized plan to every patient as soon as we confirm the medications, the protocol, and what kind of steps needs to be taken in terms of investigations. And the treatment is provided nationwide. So one fee is the actual IVF procedure, the egg collection, embryology fee, and the fertilization, which also includes the fresh embryo transfer. And then something that we call management monitoring fee, which includes all of your blood tests during the treatment, ultrasound scans, mobile phlebotomy, private couriers to collect the blood test from your home. And yes, we do blood tests during the IVF cycle from the comfort of your home. We have around, I think, 5,000 nurses on the contract that are available nationwide. And then during the IVF cycle, to make the process less stressful and help you to navigate during the busy scheduler, we organize the nurse to come to your home, take a blood test, and then our courier can collect the sample and we will receive the results within 4 to 5 hours. And then the procedures like blastocyst culture and embryo freezing, if there will be any remaining embryos to freeze, there is no any cutoff on how many embryos can be frozen. The fee will apply for as many as there will be for you to freeze, and the HFEA fee and medication delivery. Now, medication protocol is the only part which will be tailored according to your protocol, and we will confirm it once Dr. Sami performs the consultation with you. Dr. Sami, you made some scribbles, but it's okay. Can you? Okay, so in terms of the network and patient support, so as I explained, we do have 450 locations across the country, and those locations is our partner diagnostic centers where we will perform the blood test, the ultrasound scan during your treatment. Dr. Sami receives all of the blood tests through our CRM system, reviews them all, and then we provide all of the instructions. And yes, so we do have a network of clinics that help us to perform the blood and ultrasound scan from the comfort of where you live, just to minimize the burden of travel and the expenses that can be occurred during the treatment if you don't live too close to a good IVF clinic. And our egg collections and embryo transfers we perform at our partner clinic in London. So you would require to travel only once, okay? And then we, Dr. Sami, would you like to go to the next slide, please? Okay, thank you so much. So, and for our clinic, as I said, we are 4 years old, but Dr. Sami and Dr. Nora has extensive experience in providing the treatment care. And in 2025, we have been recognized by multiple awards. And the latest award Dr. Sami received as the highly commended best fertility doctor. And yes, so that was a great proud moment for Plan Your Baby. And just to tell you more, a little bit of our services, how we provide them. So Plan Your Baby is the clinic that opens 7 days a week with no days off, because we understand that we can't adjust your cycles, your body to Monday to Friday. So that's why our doors are open 7 days a week. And we do work different hours. We work from very early in the morning until very late in the evening. And if you would like to speak to our nurses, you will have access to us either via phone call, email, or the WhatsApp as well. And in terms of the treatment, we deliver all of the medications to your doorstep. And then Dr. Sami, if you would like to go to the next slide. So yes, and the reason why we have created the treatment to be so convenient, comfortable, and accessible is because during our careers we have witnessed many stories, and really made us feel that in 2025 the treatment shouldn't be offered in a very old-fashioned way, and everyone has their own lives. And when it comes to infertility and the psychological impact that it makes, so we really would like you to feel cared and looked after. And that's why we've decided to make the clinic being so accessible in terms of the services. And Dr. Sami, would you like to go to the next slide? Yes, so who would like to book a consultation with Dr. Sami? You have an opportunity to scan the barcode. Otherwise, you can access to the link in our chat. And we will start the Q&A session. And I can see we have many questions already in the chat. And we will try to answer them all, and we'll try to provide all of the information. And of course, for us, the most important is to hear your feedback. And please let us know if the session has been informative, if you found it useful, and any feedback you would like to share, please let us know. You have our email, our phone number, and as well the QR code to scan. Dr. Sami, would you like to, if you would like, you can stop sharing the screen, and then we can start the Q&A session. I know we have many questions, and hopefully we will be able to answer them on. And the first question would be, in terms of the packages. So Dr. Sami, do we offer an IVF packages, and how would you structure the treatment protocol?
Yeah, so I know there are many clinics that do this package system where it's all inclusive, all the tests and drugs, everything is included in one fee. We don't do that at Plan Your Baby because I don't feel that there's a one-size-fits-all process where everyone needs exactly the same thing to be done exactly the same way with set amounts, etc. So it's an individualized protocol that we'll make based on your history, previous results, previous IVF cycles if you've done them, and then based on that, I will make the protocol, and then the patient will receive a customized breakdown of the fees, and then you'll understand what's involved, what's included, but it's not a package that we offer to everyone in the same way.
Thank you so much. No, I think we have another question. Good evening, I'm Selena from Brighton. She's 39 years old, and she had 2 miscarriages after conceiving both pregnancies naturally. And Nora, any advice you can give for this lady, and anything can be done just to make her to have a successful pregnancy and a live birth?
Yeah, so thank you for that question. The first thing is that I'm going to make sure that she understands that it's nothing she's done wrong. I mean, she's able to get pregnant, but not carry on with the pregnancy. One of the things that we would look into is the history and get more information about when the miscarriages happened, was there a heartbeat or not, and see if there's any other medical conditions. We would offer different testing. So one of the tests that we do is to look for something called antiphospholipid syndrome, which is autoimmune. We do blood tests for thyroid, and we do a scan for the womb to check that the anatomy is normal. And depending on other factors, we may offer immune testing. So sometimes if we find something like for example, sticky blood, we can offer low molecular weight heparin or blood thinners and some aspirin, and that can increase the live birth rate from 10 to 15% up to 80% if that was the reason of recurrent miscarriages. So it's really important to personalize it.
Thank you so much, Dr. Nora. Thank you. We have another question. Poor lady. She had 5 failed IVF cycles and 3 pregnancies. 2 ended under 9 weeks. And also she has adenomyosis. And she doesn't have any blood disorders and haven't done PGT-A testing. So have transferred over 8 embryos now. And what more can be done? She's 36 years old and she has been on the IVF journey since age of 30, so young.
Yeah, so I'm really sorry for this lady. It's a long journey, and unfortunately she hasn't had success. And yeah, I can't imagine transferring so many embryos, 8 embryos, and not having a successful pregnancy. It must be really, really tough. But it does kind of suggest that there's something else going on, because even without PGT-A testing, you know, having such a big number of embryos transferred for a young lady without a successful pregnancy is unusual. And there needs to be in-depth investigations done before any further transfer. So certainly if she hasn't done, for example, chromosome karyotype testing, that should be done. If she hasn't done a good way of screening the uterus is either to do a saline scan where water is injected to the womb to make sure that you're not missing small polyps, fibroids, scarring. That should be done, or a hysteroscopy is an alternative way to do that, which is telescope to look inside the womb. Microbiome testing, I would suggest, and definitely immune testing with so many embryos. I think that could be a likely factor, especially in a younger patient, because I'm not sure PGT-A would make a big difference, but if the chromosome karyotype is abnormal, then yes, that could be a reason. If one of them has what we call a balanced translocation, where one part of one chromosome is swapped with another part of another chromosome, then this increases greatly the chance of there being abnormal embryos, and actually the majority of embryos are going to be abnormal. And in this situation, for sure, there should be genetic testing done on the embryos before transfer. But yeah, I think we just need to see what she's done and what she hasn't done, and make a plan based on that.
Thank you so much, Dr. Sami. And yes, we have shared some case studies, and just to send a little bit of hope and encouragement that despite of, you know, so many IVF cycles, still please believe that it can happen. It's just very important to understand the actual reason why you have had so many miscarriages and implantation failures. Dr. Sami and Dr. Nora, another question. So after 3 miscarriages, lady tried an IVF. So 12 eggs. So the 12 eggs were only one got 1 embryo, graded B. The others were not suitable for freezing. The cycle was not successful. Would it be worth doing the genetic testing with only 1 or 2 embryos? And in terms of the cost, then I can answer this question, how much it may cost.
I think what's important is also her age, which she hasn't mentioned, because if it's an older lady above 38 years, then I think it probably is worthwhile doing genetic testing, because for sure the commonest reason would be for the miscarriages would be a genetic problem, and transferring untested embryos, either there's not going to be a pregnancy, or if there is, even worse, she's going to have another miscarriage. So certainly for an older lady, I would encourage her to do genetic testing. Even if it's 1 or 2 embryos, it's her choice. I mean, she doesn't have to do it, but if she's, you know, trying to minimize the risk of miscarriage, then that could be a way to do that. But for younger women, I'm not sure. I think there may, again, need to be further investigations done, looking at things like the immune, the uterus, checking everything that we can check, optimizing whatever we can, you know, thyroid, checking prolactin, hormone, blood sugar control, all of these things we want to try and optimize. But yes, I still think hopefully she can be successful. It's quite a low number that she got, from 12 eggs, only 1 embryo. Sometimes, again, for older women, we see quite a big drop off in numbers, but for younger women, that's a little bit strange. So sometimes it can be that you change the way that the IVF is done, what medications are done, the protocol. Sometimes that makes a difference, not always, of course.
Thank you so much, Dr. Sami. And in terms of the cost, the IVF cycle approximately will cost about 8 to 10,000 pounds, and then depends on the embryos. The genetic test is 450 pounds per embryo. So there is no any biopsy or setup fee. You just pay for the embryos that needs to be biopsied. That's it. We have another question. To be honest, I didn't realize how hard it's going to be to read all of the stories. I have had more than 8 miscarriages and 2 ectopic pregnancies. The lady is 41, and what can be done? This is really heartbreaking.
Yeah, so with recurrent miscarriages and ectopic, sometimes there's a genetic factor under it. So I would see how old she is, and I would offer genetic testing, for her and her partner, if they're providing the sperm, and make sure if there's any translocation, as Dr. Sami mentioned as well, that then we can do specific testing for the embryos, and maybe that can reduce that. And also we will search and investigate for other reasons like the sticky blood and immunes.
Thank you so much. Dr. Nora, can I ask you a question? When we see patients with so many miscarriages, do we offer an extended carrier screening in those situations, or this kind of test would not be considered?
It's not routine to offer extended carrier testing, but there have been certain syndromes that have been discovered to be a cause of these high numbers. And I have seen someone with 10 miscarriages and 2 ectopics as well. And at the end, it was a genetic thing. Very rare, but they can get a license for the embryo testing for that.
Thank you so much. We have another question. Do we do DNA fragmentation test, or PGT-A is the only considered test when we see recurrent miscarriages?
So DNA fragmentation test is a special test on the sperm to check how fragmented the DNA is, and it gives you a percentage as a proportion. So it comes up 25%, 40%. Ideally, you want to see in most tests 25% or lower. Now, to do this test, you actually destroy the sperm, so you can't use sperm which have been checked for DNA fragmentation. And this is a problem because, okay, we have the percentage, it may be like 30% or 35%, but what can you actually do about this? Well, what normally we do is we ask the man to try and focus on his lifestyle and diet. So healthy lifestyle, cutting down alcohol, caffeine, smoking if he smokes, healthy diet, taking some supplements, male fertility supplements, frequent ejaculation every 2 or 3 days, avoiding heat. These are all things that we recommend when the fragmentation is high, but actually we recommend these for any man who is trying with his partner for a baby, no matter what the situation is. So they should do that anyway. So I don't normally recommend people to do this test because I don't see how it will change the management or what we do. Yes, we can do the test. We can arrange it through Plan Your Baby if someone is really desperate to know it. But in terms of my process, my treatment, it's not going to change anything at all. And yes, doing genetic testing will actually tell us about the embryos that we have in hand, if they are genetically good or not, unlike the DNA fragmentation. And I'll just add here that even when the fragmentation is very high, I've seen men with extremely high fragmentation, 70, 75% fragmented sperm. I've seen many of these men then go on to have live births, even naturally. So it's not something that prevents you from having a baby. You only need 1 good sperm, 1 good egg, 1 good embryo to have a baby. And therefore, I don't recommend a test normally, but sometimes we do get patients, they're very desperate to do it, and they can check it if they want. I think it's around £500 it costs, something like that. So it's not a cheap test either.
Thank you so much. And Dr. Sami, can I ask if you could answer in terms of the miscarriage, to have a miscarriage, what are the risks for those who are having a very high DNA fragmentation rate? Is it increased or it stays the same?
It's increased. So if the man has high fragmentation, then the studies have shown that there's a higher risk of miscarriage. Higher risk of miscarriage, lower chance of pregnancy as well. But the problem is, what do we do about this apart from healthy diet, healthy lifestyle, supplements, etc.? Nothing more we can do. And sometimes doing those things over a few months, I remember I used to do this test more than 10 years ago, and we did used to repeat it, and it sometimes see quite significant reductions in just doing those simple steps. but not always. So ultimately, what do you do about it? You just recommend the lifestyle and diet, and that's all you can do anyway.
Thank you so much. We have another question. If it tested chromosomes problem, then is there any way to improve or to get pregnant not through donors? I believe the question is around maybe a karyotype test, the chromosome karyotype, the own chromosomes. Yes, that's actually a very interesting question.
Yeah, and just to mention, I know we spoke about PGT-A here, but there is something called PGT-SR. And PGT-SR means that it's a specific testing for any shuffling or shifting in the DNA. So if that is the reason for the miscarriages, it can be done, and only balanced embryos transferred.
Thank you
So
so
it's
much.
for chromosomal rearrangements. That's the other word if you want to search.
Yeah,
Yes,
but
thank you so
the
much.
thing is, when we find problems like this, we refer the patients to a genetic counselor, and the genetic counselor will look at this specific rearrangement. Because I'm not the geneticist, I know there's a problem, but I don't fully appreciate the extent of this problem for this person. But the genetic counselor, this is what they're trained for. They're actually not counselors, they're geneticists, they're scientists, and they can look at it and advise the patient and us on the chances of having healthy baby. And the best next steps. And most of the time they will say, yes, there's a 10% chance, 30% chance of having healthy baby with genetic testing. So again, there's some luck involved. Sometimes, unfortunately, we do run through the cycle, make the embryos, test them, and unfortunately, we don't get any healthy embryo, and the patient has to think about trying again if they can, afford to try again. And that's always a scenario that we may have to face, but still, it's good to understand the statistics and the likelihoods.
Thank you so much, Dr. Sami. And at Plan Your Baby, we do have a geneticist with more than 30 years of experience. And for very, I would say, complex cases, we always refer to geneticists to make sure that we understand the solution, the chances, and what to expect from the future attempts. We have one more question. If someone is making good number of euploid embryos, would it be leaning more towards the uterus being an issue and not the embryos itself? If in this case, would you also advise surrogacy? And the subsequent question, what treatment protocol would you advise for adenomyosis in this situation?
So yes, I mean, it's good that this patient is making a good number of euploids because sometimes that's where the difficulty lies. But even with a euploid, even with a tested healthy embryo, it's not a guarantee that you'll get pregnant with that embryo. And there are, we're only testing one aspect of the embryo, which is the chromosomes, the genetic makeup. There's more to the embryo than that we don't know. And you can be unlucky that there may be something else wrong with that embryo, which then stops it from developing and implanting in the correct way. So even with euploid embryos, we said that we get around 50 to 60% chance of a baby per embryo, but each embryo is unique. So if someone is transferring multiple euploid embryos and not getting pregnant, like the first case I gave the example of, then yes, there is something wrong with the environment. The embryo is not in the right environment, and that's why it's not implanting, or that's why this woman is miscarrying. And we need to adjust the environment to make it favorable. So there needs to be, again, extensive testing done to check all the factors that we can, the hormones, the uterus, the immunes, the clotting needs to be addressed. Everything we can cover for, we should cover for. Again, we can never guarantee 100% that will lead to a successful pregnancy because there's more things that we still don't fully appreciate and understand and have treatments for. But that should give a much better chance per embryo that there will be a success than if you miss these things out, especially when someone's repeatedly failing with euploid embryos. It really necessitates a deep thinking and planning and understanding of this patient before proceeding to transfer these embryos, because they are valuable and precious. Now, for adenomyosis doesn't, in my opinion, need a specific protocol. It doesn't affect the egg quality or embryo quality. It's nothing to do with that. It's all to do with the uterus. And if someone has severe adenomyosis, yes, there can be a reduction in the chance of pregnancy and slightly higher risk of miscarriage too. But I've seen so many women in my career who've got severe adenomyosis. I mean, when it's mild or moderate, I don't think it has so much of an effect, but severe maybe. But I've seen so many women with severe adenomyosis in my career who were told by other clinics, other doctors, that your uterus is in bad shape, you're not going to get pregnant with this uterus, you're not going to have a baby with this uterus. You need to think of donor, or not donor, surrogacy or adoption. And then I've seen them be successful with their own uterus, with their own embryo, not at all what they were told, just with the right attention and support for other factors which may be present. So I think there's not like one specific protocol for any woman with adenomyosis that needs to be followed. I think every woman has to be looked at individually, every couple have to look at individually, and then the right protocol is made.
Thank you so much, Dr. Sami. We have another very interesting question. I've heard that IVF can eventually lead to cancer. Heard of a few examples. One of the ladies had 8 rounds of IVF and now is fighting with breast cancer. And this isn't the only case. So how IVF impacts the woman's body and also any benign breast lumps. And this lady is also mentioning that she saw the clinic that offers natural IVF when it's adjusted to the natural cycle without hormonal stimulation. And so if we could share any information and how exactly the natural IVF can reduce the risk of breast cancer. Dr. Nora, would you like to answer this question?
Yes.
Well, you can start. I'll talk about the natural cycle.
Okay, because I was going to even address that. So first of all, I don't think there's any evidence that the IVF will increase breast cancer. We actually do egg freezing and fertility preservation for patients with breast cancer before they start their chemotherapy treatment. For cancer to develop, it takes many years. I appreciate there's an increase in hormones, but even cancer has different types that are not hormone positive or don't respond to hormones, and there's no evidence that showed that IVF can cause breast cancer. Just to reassure you as well, I mean, you can have that case happen here or there. They might be an underlying genetic predisposition that may have, or coincidence that that person may have developed the cancer. We do see patients with breast cancer that come back 2 years after having treatment to get pregnant, and hormones in pregnancy are also very high, and their oncologists are happy for them to get pregnant. Do you want to go with the natural? Because
Yes, no. So the natural cycle is actually something I do, modified natural cycles. I do believe that women with very low egg reserve don't do so well when you stimulate them with strong hormones, with high doses. Even when you give the highest dose you can, you typically just get 1 or 2 eggs. And therefore, there's no benefit to giving the high dose, lots of side effects and increased cost. And sometimes it's better just to go with a much more gentle approach, which is the modified natural cycle. However, even with modified natural, it's not meaning it's completely natural. It doesn't mean that there's no drugs. Because if you do completely natural, it's, well, first of all, normally a natural menstrual cycle, one is only going to produce 1 egg. And with IVF, we want to try and get more eggs, because more eggs means more embryos, more chance. With 1 egg, it may not be a mature egg. It may not be fertilized with the sperm. It may not make it to an embryo stage. It may not be a good embryo. So there are a lot of hurdles that we need to get through, and doing IVF isn't something easy or cheap, and you need to go through a procedure with anesthetic and risks associated with the needle going inside the body. So if a woman is likely to produce multiple eggs, then I don't see why you should just go with the 1. Not only that, you need to give some drug to suppress ovulation, because when IVF started in the very early days of IVF, that's what they did. They did natural cycles. And 35% of the time, the egg would release before they got the chance to collect it. So the woman would end up with nothing, and they'll have to do it again, another cycle, which is a terrible shame, really, if you lose that, all the eggs. So nobody I know of nowadays is doing completely natural cycle. Usually it's modified natural, which means a lower dose of the drug, which can result in lower hormones compared to the full stimulation, but it's still much higher hormones than what you get naturally in a completely natural cycle. And I don't think that even for patients with breast cancer, that should be something that we would just say, okay, because you have history of breast cancer, even hormone sensitive, that you take a very tiny dose of medication, or we just get 1 egg from you. I don't think that's the right approach. And usually with the patients who have a history of breast cancer, especially hormone sensitive, we give them a drug called letrozole, which helps to minimize the estrogen level, because estrogen is the hormone that causes concern with some breast cancers are estrogen sensitive. So we give this drug alongside. We give it to women as well who don't have breast cancer, of course, but for women with breast cancer, we give it throughout the whole cycle to minimize the estrogen level, And that can be a way to protect them as well during the stimulation. But the stimulation is only a couple of weeks, and then we collect the eggs, so it's not a very high risk.
Thank you so much, Dr. Sami, Dr. Noor, for such an extensive answer. It can be, I understand, can be very scary, especially if you read a lot in the news and even more see some cases with the cancer. It can be very, very scary. Another very interesting question: do you test the blood for the thick blood syndrome, as this can be a reason for recurrent miscarriages even with IVF? If yes, do you prescribe any medications during the IVF treatment?
I'll answer that one. So I don't test normally most things to do with sticky blood. I will test for antiphospholipid syndrome sometimes because that has much more widespread implications. But just purely for blood clotting disorders, I wouldn't check, because number one, there's so many tests, so many things that are included in the clotting cascade that you can't really test for everything. It's not practical. So even if you've tested a few, it doesn't mean that you've excluded other things. And number two, I feel that for patients with recurrent miscarriage, to maximize their chance of there being a successful pregnancy, I will give them blood thinners in the first trimester, in the first 12 weeks. So for my patients who have had recurrent miscarriage, I will offer them blood thinners without doing these tests. Because even if I did do the tests, I might not be able to pick up something, and then that might still lead to the miscarriage happening. And they've already been through a lot of horrible experiences with miscarriage. And, I just want to make sure that at least this thing is covered for, because the treatment for any clotting problem is pretty much the same. It's to take the blood thinning injection, the heparin injection, and the aspirin together.
Thank you so much, Dr. Sami. I know we don't have much time, but I will try to go through all of the questions that we still have in the chat. So one more lady, so she has done blood test from with a private clinic, and all of the tests came out all good and no issues, and also she did the immune test. Now the doctor said, we don't suggest DNA check since you both we do suggest DNA check since your both reports are good. So the lady wants to know what would we suggest in this situation.
Yeah, I think if she's young, especially, and she's had failed IVF repeatedly or recurrent miscarriage, then yes, and the immune test and everything is looking okay, then I think it's important to check the chromosome karyotype. It's not a common situation with the balanced translocation that we mentioned before. It's rare, but if you have that, it's better to know about it than not to know, and you keep going through cycles blindly or getting pregnant naturally blindly, and then ending up with recurrent miscarriage or IVF failure or whatever. So I think yes, especially if they're young. I mean, we don't have much details really here, but if it's a young patient with recurrent miscarriage, recurrent IVF failure, then I would probably suggest a chromosome karyotype to check both of their DNA, yes.
Is it okay just to add one comment about recurrent miscarriages? It can be a really frustrating problem, and it's not always that we can pinpoint the reason, because there are some things on the molecular level which science hasn't discovered yet, but at least we can offer some help along the way.
Thank you so much. And yes, I think that answers the next question, Dr. Nora. If we actually, by looking at the full case history of a patient, can we 100% understand the reason of the miscarriage?
So I can't say 100% that's a lot, but there are some hints sometimes in the history. If there was a baby's heartbeat seen and then this baby's heartbeat disappeared, with the next scan, and this is a repetitive thing, then we would think about antiphospholipid syndrome. If there are any other symptoms, they can suggest that there is a septum in the womb, and we can do a 3D scan for that. So these are just examples. Dr. Sami?
Yeah, no, I agree. I mean, I think we have to kind of look at the history, and sometimes there are clues. Maybe the lining flume isn't thickening up, or there may be scarring from previous miscarriages having had surgical evacuations, or sometimes, we feel that there's something from the history which could suggest autoimmune disease, things like that may give clues, but sometimes we don't have clues, and, someone is really healthy and everything is good from the history. So the investigations are then done to screen and try and see if we can pick up a problem, but there are sometimes we just don't know, in which case we'll, it doesn't mean that there's no cause, it's just that we haven't managed to put our finger on it. And we can still try with giving coverage for things like blood thinners, and I mentioned before that for my patients, I would offer them blood thinners if they've had 3 miscarriages or more. Progesterone support, monitoring the pregnancy, all of this we can offer, and hopefully we still get a lot of people like that where we don't know for sure, and they're successful in their pregnancy. So there's still hope, I think.
Thank you so much. A few more questions. I have severe adenomyosis, 2 biochemicals with donor eggs, since had immune testing, which has shown elevated natural killer cells and Th1 dominance. So would intralipids and prednisolone be enough to counter this? And I have done suppression of 3 months before each transfer as well.
Okay, so I think it depends on the exact which natural killer cell is high, how high it is, as to which treatment I would recommend for the killer cells. In the 2 examples I gave, the case examples, they both had a different type of IV drip called IVIG, and some patients I do feel that is what they need to give further suppression. The Th1 dominance, the cytokines, I don't usually give intralipids prior to the cycle. Most likely I would give either an injection called Humira, which was given with the second case that I gave the example for, or sometimes I give tablets called hydroxychloroquine, usually for a couple of months before we do any embryo transfer. And then during the cycle itself, I would cover with maybe intralipids or maybe IVIG, depending on the exact levels and which killer cell is high. And steroids I would give, again, it could be prednisone, it could be dexamethasone, depending on what exactly. So I don't think it's a blanket treatment just to high NK cells or Th1 dominance. There's one treatment that's given. I think it needs to be tailored according to the actual result.
Thank you so much. Another question, is there a higher probability with IVF of carrying full term or past 12 weeks versus continuing naturally? So I've been trying to conceive for 4 years with recurrent miscarriage pregnancy each year. However, since fibroid removal last year, no pregnancy. I've noticed my cycle changing each month by a few days, and letrozole was trialed. I've had testing, slightly raised TPO antibodies. However, I was advised steroids could increase chance of disability in baby. So would you recommend continuing to try naturally with these medications before pursuing IVF? Lady is 38 years old, and is there a latest age you would consider commencing IVF?
To be honest, because of the history of my fibroid removal, I'd like to know how many fibroids removed, what's the extent, and offer a check for her tubes to make sure that they're open so the eggs and sperm are actually meeting. If she's been trying for so long, then you can just go ahead with IVF and bypass. But I would start with that. I would check her periods if they're lighter or not, and make sure her cavity also is clear.
And I'll just comment about the steroids, because the steroids, when we give them in the first trimester only. So once the 12-week mark is reached, we stop the steroids. We bring the patient off them gradually. And with this kind of use of steroids, it's not likely to cause problems, because one of the problems if you continue steroids into the pregnancy till delivery is that the growth of the baby can be affected, but it's not something that will affect in the first trimester. There was a study that was done a long time ago on rats, in fact, that did show there was a higher risk of cleft lip and cleft palate when steroids were given in the first trimester. But this has not been reproduced in further studies, and steroids are not a new drug. They've been around for many, many years, decades, in fact, and been used by pregnant women for decades, because some women, especially with autoimmune disease, they end up with flare-ups and they need this steroid treatment in very high doses, much higher than what you would ever dream of using. And they take them in pregnancy, and still, there's not really been any evidence that it causes birth defects or disabilities in the child.
Thank you so much, Dr. Sami. I've just noticed the time, and we still have so many questions to answer. So I will highly encourage everyone, if you feel that we have not answered the questions, please feel free to email us. You can email to nurses@planyourbaby.co.uk, or you can book a 15-minute call with our nurses, and we will be happy to answer your questions. And yes, just if Dr. Sami, for maybe 30 seconds just to cover the last one, and then unfortunately we will have to then answer all of the questions over the email or take them outside of the webinar. So there are risks that DNA fragmentation test can damage the embryo and the child will have some abnormalities, health issues. And how big is the risk, Dr. Sami, and can it be prevented with IVF?
So the test won't damage anything, of course. It's the fragmentation if it's high. It's not been associated actually with health abnormalities with a child. It's associated with reduced chance of pregnancy or higher risk of miscarriage. And again, you know, I've seen men with extremely high fragmentation, sometimes 70, 75%, which is extremely high. It's rare to see this level of high fragmentation. And yet still, I've seen these men go on to have healthy children, and some of those men even naturally. So that wouldn't be something which the DNA fragmentation test will tell you. Now, if you do IVF, we can sometimes recommend the PGT-A that we've talked about tonight, and that can reduce the risk of things like Down syndrome, Edwards-Patous, Turner's, Klinefelter's, because these problems are all down to number of chromosomes in the baby, and if the number are not right, then we won't transfer that embryo. And it minimizes the risk of these things happening. It doesn't eliminate completely because it's 98% accurate, but it makes it very, very unlikely to happen. So that can be helped with IVF if you do genetic testing. But again, I don't believe genetic testing is for every single person doing IVF. I think, you know, we need to look at the whole picture, really decide that.
Thank you so much. I know we've run out of time, and I want to thank absolutely everyone who joined this webinar. I know this topic is very, very sensitive. It can be very heartbreaking, and it's very hard to go through this journey. So please remember, there can be a success and happy end, and we are here to support you. And Dr. Sami, Dr. Nora, thank you so much for answering on all the questions and helping so many women who joined us tonight. And yes, please send us an email if you feel that we have not had a chance to answer your questions.
Yes, thank you everyone for joining, and yeah, I wish you all the best of luck. Hopefully you'll be successful soon.
Good luck.
Thank you so much. Have a good night, everyone. Thank you.
Thank you.